Welcome to OAC Health Talks. I'm Joe Naglowski, President and CEO of the Obesity Action Coalition, and we are excited for you to join us for this educational series that dives deeper into specific health topics that we know are important to you and the OAC community. Health Talks are designed to empower you while providing straightforward, practical answers and insight from trusted experts. So let's dive into today's topic.
It's a pleasure to join you today. I'm Lee Kaplan, and I'm going to talk today about obesity as a disease. As you can see from this slide, I often say that obesity is a disease like no other, but today I'm going to talk about how obesity is a disease like every other and should be considered and approached as such. So what is obesity? Obesity, according to the World Health Organization, is a disease characterized by abnormal or excessive fat accumulation that presents a risk to health. More commonly, we think about it as a complex, chronic, and I would argue possibly progressive disease. It seems to get worse, but we're not really sure. And you'll notice I have taken the word relapsing out of it, because relapsing diseases are typically diseases that get worse and get better on their own, like autoimmune diseases and others, whereas obesity tends to get worse after an attempted therapy has not been as successful. It doesn't really by itself get better, get worse, get better, get worse without intervention. Now, why is it a disease? I would argue it's a disease because it results from abnormal metabolic regulation of body fat mass. After all, body fat mass is where we store our energy, so it's an abnormal regulation of energy stores. And if we had a flexible gas tank in our car, it would be an abnormal regulation of the size of that gas tank, which could lead to us carrying around too much gasoline, which would be inefficient. Alone, though, obesity, whatever its cause, causes pathology and diminishes health. You don't need complications, but it's also a risk factor for more than 225 other diseases. So it is a risk factor. It does cause other diseases, but it's a disease in its own right. And there's a lot of controversy about what causes obesity. We know that genetics are involved. We know that the modern environment is the trigger of the whole process. But at the end of the day, no matter what the cause, the final common pathway of obesity is inside the body. And another way to think about that is there's an epidemic of autoimmune inflammatory disease. There's an epidemic of food allergies, particularly nut allergies. And we know that those nut allergies probably come from changes in the modern environment, just like obesity. But we wouldn't debate if somebody is having a major immune reaction to peanuts, for example, that there's something wrong with their immune system, even though the cause of the disease was changes in the modern environment. And we ought to think about obesity in the same way. Changes in the modern environment are what's causing obesity, but obesity is a disease that results from disruption of normal physiology, and we'll get back to that in a few minutes. Now, the fundamental question, though, is not really whether obesity is a disease, it's who should be taking care of it. Is obesity a disorder that's should be treated within the healthcare system, or as some would argue, in a shopping mall? And in fact, we have places in the shopping mall which try to treat obesity. And I'm going to argue that it does belong in the healthcare system, and not simply because we call it a disease, but because of characteristics of obesity that make it appropriate for treatment in the healthcare environment. Now, what's the purpose of healthcare? Well, the purpose of healthcare, really, in one way to look at it, is to relieve suffering arising from disturbances in the human body. From symptoms, obviously we want to relieve symptoms, whether they're pain or nausea or something else. We want to relieve disability. And we want to relieve fear of complications, of dying, of developing a disability in the future, of not being able to live a good and productive life. And if the goal is to do the things that are on this slide, then the healthcare system is the appropriate place to pursue that goal. That is the purpose of the healthcare system. Well, obesity is a disease with prominent symptoms. Unlike many other metabolic diseases such as hypertension, diabetes, high cholesterol, liver steatotic or fatty liver disease, chronic kidney disease, until they get to the final stages, they don't typically cause symptoms. The only way you know about them is a blood test or an imaging study. But obesity causes symptoms that can be used to stimulate and to monitor the effectiveness of any therapy that we use. Those symptoms fall into three major categories: appetitive, or changes in appetite; physical functioning, or dysfunctioning; and dysphoric, meaning some disturbance in happiness or good cheer. The common appetitive symptoms include excessive, often controllable hunger. In its most severe form, it's called hyperphagia. Or even if you're not always hungry, the inability to achieve fullness or satiety after a meal. But most commonly, the symptom around appetite that comes from obesity is a preoccupation or obsession with food and meal planning that's often called food noise, that interferes with life because so much time of somebody who has obesity is spent contemplating, planning, etc., around food consumption. And it's not their choice to do so. Now, these symptoms, these appetitive symptoms, typically respond quickly to effective anti-obesity therapies, often within days, before any substantial weight loss occurs. And we should keep that in mind, because we can use those symptoms both as a measure and as a marker of what's going on when we treat. Now, the second type of symptoms that you see with obesity are physical functioning symptoms, particularly with more severe obesity. Difficulty breathing with minimal exertion in the absence of heart disease, in the absence of lung disease. So obesity itself can cause that. Difficulty or inability to perform normal activities of daily living because of the size of someone's body or the shape of the body, particularly hygiene-related activities, or standing or sitting in certain positions or for prolonged periods of time. Decreased stamina in general is a hallmark of more severe types of obesity. In addition, discoordination from alterations in body shape and elevated center of gravity, leading to increased risk of injury or injury itself. And finally, the dysphoria, leading to depression, anxiety, social isolation, and eating disorders, that which can arise from stigma, from discrimination, from social exclusion, and also from the frustration arising from society's expectation, maybe even healthcare providers' expectation, that willful dieting is all that's needed to solve the obesity problem for any individual. And supportive, non-stigmatizing care can provide early improvement in dysphoria. That aspect, that symptom that's associated with obesity can be improved if healthcare providers understand obesity well enough and provide the supportive environment that can start a patient on the journey toward a healthier and more productive life, at least with respect to their obesity. Now, it's important to recognize that obesity sits within society and needs to be distinguished from what I like to call the cultural desire for thinness. There are people, shown here on the right side of this Venn diagram set of circles, who simply want to lose weight because they want to lose weight, maybe 2 pounds, 5 pounds, 10 pounds. But they don't have obesity. And society frequently confuses people who want to lose a few pounds, just because they do, from people with the disease of obesity. Now, you can have both, and you can see these two circles overlap. And when somebody does have obesity and they also have a desire to lose weight, whether cultural or health-related or whatever, we can use that desire to lose weight as help for the patient in complying with care, in seeking care, in working with providers, and in pursuing their own forms of care without the healthcare system. So when you have obesity and the cultural desire for thinness, the obesity dominates. It's a reason, if you wish to be treated. But when you only have the cultural desire for thinness, what that does is it confuses policymakers, it confuses healthcare providers, it confuses payers to think that everybody who gets treated and wants to lose weight is doing so only for social reasons or cosmetic reasons, which undercuts our ability to provide the kind of care that we need to, and makes access to effective care less for those people who most need it, those people with obesity. Now, let's go back to obesity as a disease. Body fat mass, how much fat we have, all of us, is regulated physiologically. It's regulated by the body according to a program that is embedded within our bodies, within our DNA. At multiple stages during development and growth, with loss of baby fat, with fat changes during puberty, with fat changes with aging, with fat changes with menopause, these things occur without our voluntary input. You don't have to put a baby on a diet to get rid of baby fat. In particular, women during and after pregnancy change their body fat substantially. And typically, although you might not be happy with the amount of weight you lose after a pregnancy, the body loses weight after pregnancy 95% of the time without any intervention. You don't have to go on a diet. So all of these things occur without conscious or purposeful input. However, when this system of normally regulating how much fat we have and where we put the fat, for example, baby fat's in a different place from pubertal fat, which is in a different place from pregnancy fat, which is in a different place from menopause fat, and yet the body knows where to put them and how to move things around. And when that doesn't work, if the end result is fat in the wrong place or excess total fat, you end up with obesity. It's a system that is not regulating correctly, which is what makes obesity a disease, whether it's from genetics or whether it's from the environment, more likely whether it's from the combination of the environment acting on somebody who is genetically and biologically susceptible. Now, for most tissues, the body seeks a target mass. That's why when you give blood, the blood will grow back to the same hematocrit or hemoglobin that it was before. If you give a piece of your liver for a liver transplant, it will grow back. Liver is not going to grow back exactly in the same shape, but it'll grow back to the same weight. And the exact same thing happens with fat. If all you do is cut out fat, and that's been done in both animal models and in people, you just go in and you cut it out, or you use liposuction to take it out. What ends up happening is the fat grows back, maybe in a different place or slightly, and you go from smooth fat to lumpy, bumpy fat, because the body will regrow fat, but it can't grow it where it was removed because the stem cells were taken out from that place. And so, physical destruction or removal of any of these tissues leads to rapid regrowth, so it turns out not to be an effective treatment for obesity if you simply remove fat. Now that's different from bariatric surgery or metabolic surgery, where you're not removing fat, you're changing the way the body regulates its fat, but we'll come back to that. So in obesity, the target fat mass, how much fat the body wants to have, how much energy it wants to store in the form of fat, is elevated because of these environmental influences on biologically susceptible individuals. The body wants to have too much fat, and it defends that amount of fat. You see that blue bar here, because that's the amount of fat the body will defend. And until maybe you get to another time of your life when the body will defend a different amount of fat. But once you have obesity, that amount of fat that it's defending, that it wants to have, is too high. And so the best way to solve that is to try to get the body to change its normal regulation so it gets back toward a lower, more normal amount of body fat, which of course the amount of body fat you have determines the amount of weight that you have. So together, what this all implies biologically is that overeating is not what causes obesity. If you have obesity, whether it be from a genetic cause or an environmental cause or a drug cause or any cause, that obesity will cause the overeating, because overeating is how the body gains the weight. So if your body wants to gain weight, if your body wants to have too much energy stored, if it wants to have too much fat, of course it will make you overeat, and that's where the hunger symptoms come in. And undereating doesn't fix obesity, and there's plenty of evidence that undereating doesn't fix obesity in the long term. But if you fix the obesity, however you do it, that will cause undereating, but that undereating will only be temporary. And that decrease in appetite will only be temporary, because once you get to where the body now wants to go on therapy, you'll actually start getting hungrier again as you get to where the plateau is. Everybody plateaus for all of these diseases. If you lower your blood pressure with high blood pressure, It won't lower it to zero. It'll lower it to a lower blood pressure and then be stable there. And that's exactly what happens with body weight, body fat, and energy stores when we treat obesity effectively. So these conclusions that undereating doesn't fix obesity, but fixing obesity leads to transient undereating, have critical implications for the long-term control of obesity. Because simply not eating does work temporarily, but the body pushes back because the body wants that excessive body fat, and we haven't fixed that regulatory problem. So effective obesity treatments, including anti-obesity medications, normalize fat mass regulation, normalize body fat stores, leading to a lower targeted fat mass, a lower defended fat mass, basically normalizing, making more effective the regulation of fat mass that we see in people without obesity. Now, just to emphasize that what I'm saying has evidence, and I can't show you all of that evidence in this short talk, but if you look at the history of treating obesity in the United States over the last 40 years, what you can see is evidenced in a program that the federal government calls Healthy People. Every 10 years, the government sets goals for different diseases, for heart disease, for diabetes, for cancers, different kinds of cancers, for all kinds of diseases. And one of those, beginning in Healthy People 2000, which started in 1990. It goes for 10 years. And in 1990, the amount of obesity, the prevalence of obesity, was about 17%, meaning 17% of people in the United States had obesity in 1990. And the goal was that by 2000, the rate of obesity would be 23% lower, or it would be about 13%. That was the goal set by our government. But in that decade, the amount of obesity actually went up by 34%, up to about 23%. And that's the starting point for the next decade. And in that decade, we said, well, we didn't do very well in the previous decade, so we're going to be more ambitious, and we're going to try to lower the rate of obesity by a third. But in that decade, so by 2010, the rate of obesity was almost 35%, or had gone up by 50% during the previous decade. Well, then we got a little bit brighter, and we said, well, you know what, we're not going to be so ambitious. We'll only look for a 10% decrease in the next decade, but it went up by 14%. And now we're in the middle of the next decade, the fourth decade of assessing obesity. And the baseline, of course, is about 37%. But already, we've only gone through half the decade. Already, it's gone up by about 11%. And the suggestion is that, or if it follows at this pace, it will go up this decade by 25% between 2020 and 2030. And this is occurring despite the fact that the amount of sugar we eat has gone down as a society, the amount of exercise we do has gone up, the amount of fats we eat has gone down. So we're eating healthier, we're exercising better, and obesity continues to go up. If obesity were a disease of overeating or under-exercising, we would see some impact of these very important and significant changes in eating and exercise behaviors, and we're not seeing any of that. And so what it suggests is there's something else going on, and that's that physiology or pathophysiology, the disruption of normal regulation that leads to obesity that I'm talking about. Now, if you look at treatments, this is a graph that shows treatments of obesity over the last 60 years. And you can see at the top, bariatric surgery has been pretty stable. It's been pretty effective. The problem is that on the left side of that bariatric surgery bar, it's bright red, and on the right side, it's green. Because during the last 60 years, the risk of bariatric surgery has improved dramatically. In fact, deaths from bariatric surgery have gone down 40 times, from about 4% to about 0.1% death. So the safety has improved, although the efficacy, the effectiveness has been about the same. At the other extreme, lifestyle therapy does work. It works in a small percentage of people, not so much because they eat less, but because when you eat a healthier diet, about 4 to 5% of people will respond to that healthier diet by losing weight. Everybody else improves their health, but doesn't necessarily lose weight. And so that's been pretty stable too, although lifestyle-based therapy has gotten more efficient and easier to administer. It's not more effective than it was many decades ago. Now in the middle you can look at drugs, and with drugs you can see with each passing half decade here, for the first 40 of the last 60 years, medications were not any more effective than lifestyle. You could add them together and get some benefit. And there's fen-phen there in the 1995 range, but even that we're not 100% convinced was as good as people said. There was a lot of talk about it, but it was unsafe anyway, so the fenfluramine was taken off the market. But over the last 15 years, we've seen the introduction of combinations of drugs and new drugs like liraglutide that are better than lifestyle substantially, as shown here in under the green section. But in the last 3 years, with the advent of new nutrient-stimulated hormone-based therapies, starting with semaglutide and now more recently with tirzepatide, we see an effectiveness of medications that is far greater than what we see with intensive lifestyle therapy, and even maybe approaching with some of the newer drugs that of the effectiveness of bariatric surgery. Both in Generation 2 and Generation 3, the drugs are also more safe than they were in Generation 1 in yellow. So we've made progress both in safety and substantially in the effectiveness of these drugs. So when we do that, it has had impact on other aspects of care. For example, these two studies, Step 1 and Step 3, look at the effectiveness of semaglutide for the treatment of obesity. And what you see here is that both of these studies are in patients without diabetes but have obesity. But the Step 3 trial includes, in both the placebo arm and in the drug-treated arm, intensive behavioral therapy. This study was done at the University of Pennsylvania, which has one of the most effective behavioral therapy programs in the United States. And if you compare the two studies, because otherwise, other than the intensive behavioral therapy that was in Step 3, the studies were designed the same way. And what you see here, if you look at these two yellow bars, is that the speed of weight loss initially was greater with the intensive behavioral therapy, because the intensive behavioral therapy targeted the amount of food people ate. So people in the study were encouraged to eat less food than even the drug made them eat. So the drug, of course, decreases appetite and people ate less. But in the Step 3 trial, they were told to eat even less. They were given targets to eat even less. But at the end of the study, you'll notice in green here that there was only a 1% difference in the amount of weight loss. And in fact, we see that in Step 3, people were beginning to gain weight back at the end of the study because they had overshot, because they did try to eat less than their body wanted. And the body said, no, I want to get into the same place. I want to get where I want to go. And you see in both Step 1 and Step 3 that the body ended up in about the same place. You say, well, maybe the intensive behavioral therapy wasn't done well. Actually, it was done quite well, because if you look at the placebo group that didn't get drug, the placebo group, you can see in Step 3, did a lot better than the placebo group in Step 1, suggesting that in the absence of effective physiologically based therapy, you get some benefit, significant benefit from the intensive behavioral therapy. But when you have a physiologically based therapy, a therapy that changes the body's regulation of fat so that it wants less fat, you see two things: an immediate decrease in appetite and an easier pathway toward a more stable low weight. And you don't need to have the intensive behavioral therapy aimed at forcing yourself to eat less food in order to get there. The body does it more naturally. So why is obesity a disease? It's a disease because it results from this abnormal physiology that effective therapies can help correct. It directly causes pathology and symptoms. It diminishes health all by itself. You don't need other diseases to do that. But it also causes abnormal physiology and disease just because of the excess fat and the inflammatory response to that fat. So it's a risk factor for more than 200 other diseases. But it needs to be recognized, respected, treated, and prevented as a disease in its own right, independent of whether it causes something else. If we want to treat obesity more effectively, therefore, we have to fully understand why it's a disease and how that disease differs from the cultural desire for thinness. We have to understand what being a disease means for the effective care of obesity. And this is one thing that we can learn how to do from studying how we treat other diseases. We have to fully understand the barriers to effective obesity care and the forces working against such care. But most importantly, we in healthcare, and anybody listening to this talk who may or may not be in healthcare, but who cares about the effective management of obesity and the normalization of life for people who have obesity, if they, for however ways that obesity may diminish health and life and the quality of life, what we have to do is keep the needs and goals of all people living with obesity in our minds, even if many of us have been previously misled by the bias, the stigma, the blame, and the discrimination that surrounds all of us in our modern society. So with that in mind, we have to tell our friends, our colleagues, the world, the public health community, the medical community, we have to tell the world a story that they understand, a story that will convince all of us that obesity needs to be taken seriously and treated seriously. And Charles Eisenstein, an author, said, the world we know it, he wasn't talking about obesity, but the world we know it is always built on a story. To be a change agent, to be an effective change agent, is first to disrupt the existing story, and second, to tell a new story so that people have somewhere to go. Then you don't just want to destroy the old story. And so the question I would have for anybody listening is, what is the current story of obesity? What do we tell ourselves? What do we tell everybody else? What does the world believe about obesity? And how does that story need to change so the world is able to approach this problem more fairly, more understandingly, and more effectively? And with that in mind, I'll remind you that there are lots of things about obesity that make it different from other diseases. But obesity is a disease like every other disease at its core. It's a disease of the human body that needs to be addressed as such. Thank you very much.
The OAC has a variety of educational opportunities for you throughout the year, but one of the best places you can turn to for quality, unbiased education is our resource library. Simply visit obesityaction.org/library to check out our brochures, articles, guides, videos, and more health talks. Also be sure to subscribe to our YouTube channel to get notified about any future educational events. Thanks for joining us.